Kia ora koutou and welcome to our digital event tonight. It's really great to have you join us. I'd just like to start with a whakatauki that I think represents research really well. Ahara, takutoa, e te toa takatahi engari, toa takatini. My strength is not as an individual, but as a collective. So I'll be your host tonight. I'm Sarah Schoenberger, the Head of Research at the Neurological Foundation, and I'm very pleased to introduce our speaker tonight, Dr Brigid Ryan from the University of Auckland. Brigid is a senior lecturer in neuroscience, and she leads the New Zealand Genetic Frontotemporal Dementia study, which is supported by a Neurological Foundation project grant. She also received a Neurological Foundation doctoral scholarship back at the beginning of her career in 2011. So welcome, Brigid.
Thanks, Sarah. Let me share my slides. Wonderful. Thanks, Sarah, and thanks to the Neurological Foundation for the opportunity to speak tonight. I'll start with my mahi. Kia ora tātou. No airangi, no kōturangi hoki o Tupuna. Engari, I tupu ake o e otipoti. Ke tamaki makoto aho e noho ana. Ko Brigid Ryan aho, he kairanga hauroro aho I waipapa taumataro. Nō reira, tēnā koutou katoa. So I'm a neuroscientist at the University of Auckland, and for the past 7 years, as Sarah mentioned, I've worked on the New Zealand Genetic FTD study, or FTD-GENS, which is a longitudinal study of a family with genetic frontotemporal dementia. My interest in young-onset dementia stems from working with this family and from me learning about their experience of dealing with dementia at a young age. I'm also involved with the Younger-Onset Dementia Aotearoa Trust, YODET, which provides services and support for those living with this condition. So this is what I'm going to cover tonight. I will start by defining young-onset dementia, and then I'll summarise what we know about young-onset dementia in New Zealand. And then I'll tell you about our latest frontotemporal dementia research. So firstly, what is young-onset dementia? It's defined as dementia of any cause that has symptom onset before the age of 65. So even if someone is diagnosed when they're 67, for example, if their symptoms started before they were 65, they meet the definition. Young onset dementia means the same thing as early onset dementia, but I prefer to use young onset because early onset can be confused with early stage dementia, which is a different thing. So in general, dementia is thought of as affecting older adults, and this makes sense because the risk of dementia does increase with age. But what's not often appreciated is that a significant proportion of those living with dementia are under the age of 65. So these photos show some New Zealand families who have generously shared their stories in the media, talking about their experience with young onset dementia. So Nick in the top photo and Rita in the bottom left photo were both in their 50s when they were diagnosed with young onset dementia. And Jenny, who's in the bottom right photo with her parents, was 36. So the most common causes of young onset dementia are Alzheimer's disease, frontotemporal dementia, and vascular dementia. But together, these causes only account for between half and 75% of all cases. Alzheimer's is much less common in young onset dementia compared to late onset dementia. It only accounts for around about a third of cases in the young onset, compared to approximately 2/3 of cases in late onset. So this means that for up to half of young onset cases, they're caused by rarer diseases, which can make diagnosis more difficult. Young onset dementia is also more likely to have a genetic cause, And this is because almost all genetic dementia has symptom onset before the age of 65. So why does age matter? Although the cutoff of 65 is biologically arbitrary, it is important in a number of ways. So firstly, the retirement age is 65, and this means that the majority of people with young onset dementia are working when they first notice symptoms. So in addition to work and financial responsibilities, many people are caring for young children or teenagers. There are also differences in the clinical profile. So for example, young onset patients are likely to be less frail, for example, and more active. And finally, and really importantly, many health systems, including New Zealand's, are generally organised by age with the cutoff of 65, which can present challenges to people who are under 65 but need access to dementia care. So in New Zealand, people often fall between the aged care and disability care sectors. So for these reasons, people living with young onset dementia face unique challenges that are different to those of people who develop dementia when they're older. And so it's useful and necessary to consider these differences. So this is what we've been doing as researchers. So our first question as researchers was, how many New Zealanders are actually affected by young onset dementia? And surprisingly, this question hadn't actually been answered before we did this work, which was published in 2022. And this was led by Gary Chung. So to do this work, we utilised New Zealand data sets which capture most of our population, which is a real benefit of the data that we have in New Zealand. And they include anonymised clinical and also demographic data that we can use as researchers. So what we found when we did this study was that there were approximately 3,500 people diagnosed with young onset dementia each year in New Zealand when we just did a simple count of all of those with a diagnosis. So we looked at data from 2016 to 2020, and the number of people, the prevalence was very similar across each of these years. So in other words, if you take 10,000 New Zealanders who are aged between 30 and 64, you would expect to find that about 14 of those people have been diagnosed with young onset dementia. And this is similar to what we've seen in international data sets. So in America, for example, there would be 12 people, and in Europe, there would be slightly more at 16. And this actually represents 7% of all people living in New Zealand with dementia. So when we look at the age breakdown, about a third of these people with young onset dementia are aged between 60 and 64, so in that older 5-year group. And the majority of them, so 70%, are over 45. So this information is all really important for healthcare delivery. We need to know the patient numbers so that we can plan for and provide appropriate support. It's also really important to establish these baseline numbers so that we know how many people in New Zealand have young onset dementia so that we can track any changes in these numbers over time. We were also really interested in the ethnicity breakdown among this group of people. So this is what I'm showing on this next slide. So as you can see here, Māori and Pacific people were overrepresented in the cases of young onset dementia. So this graph here shows the number of people in each ethnicity group. And you can see that Māori people, who are represented by the purple bar, and Pacific people in the blue bar, have a higher number of cases than European and also Asian ethnicities. And these differences are actually more pronounced in young onset dementia than they are in late onset dementia. So when we look at older people with dementia. And what this finding means is that we need dedicated and culturally appropriate resources for these populations. So it's also really important to know how many people are newly diagnosed each year. So this work was looking at all people who had a diagnosis in a given year, whether they had just recently had that diagnosis or whether they'd had the diagnosis for a long time. But it's also really important to know how many people are getting a new diagnosis each year. So that's what we've had a look at in this paper. And this work was led by Etu Ma'u, and this was published in 2022. So what we did with this work was check through all of the records from Waikato Hospital and one of the private neurology clinics in the Waikato region. And we identified that in total, there were 64 new diagnoses of young onset dementia in the Waikato region over a 3-year period. So this was between 2015 and 2018. And if we extrapolate this to the whole country, we can estimate that there are probably around about 220 new diagnoses of young onset dementia in New Zealand each year. And again, when we looked at the ethnicity in this data set, this suggested that there were higher rates of young onset dementia in Māori compared to non-Māori. So we've also done some work using routinely collected medical data to compare the health and well-being of New Zealanders with young onset dementia. So this research was really trying to understand not who is affected, but how are people affected, and specifically are there differences between the experiences of people with young onset dementia compared to people with late onset dementia in a New Zealand population. This study was using some really amazing data that we have access to in New Zealand, which is the Inter-Eye New Zealand data, which is again routinely collected data. And what it allowed us to do was to compare over 1,300 New Zealanders with young onset dementia to over 45,000 New Zealanders with late onset dementia. So again, we're looking at a really large population here. And these data showed us that there are really important clinical and social differences between the younger group and the older group. And I've highlighted some of these differences here. So what we found was that there was a higher prevalence of neuropsychiatric symptoms. So that's things like anxiety and depression, and also problematic behaviors. So that's things like being aggressive. And these were both higher in the younger groups. And we also found that young onset dementia patients were more likely to experience financial strain. And that makes sense if we think that these people are more likely to have to stop working or retire earlier because of their condition. The care partners of people with young onset dementia were more likely to experience distress, anger, or depression. And also they were more likely to feel overwhelmed. So this study really supported the conclusion that age does matter for New Zealanders with dementia, and people with young onset dementia really have unique challenges that they're facing. So as I've already mentioned, diagnosis of young onset dementia can be more challenging than diagnosis at an older age. And one reason for this is that there are many different causes of young onset dementia. So identifying the cause can be more difficult than it is with late onset dementia. And also it makes sense that dementia is less likely to be suspected in younger people. But we know that timely and kindly diagnosis is really critical to both patient and care partner well-being, even in the absence of available treatments. And this is a particularly hot topic at the moment internationally. There was an Australia and New Zealand article last year that was advocating for improved diagnosis in both of our countries. And I think the authors summarised the problem really well when they wrote, "Diagnosis delay creates a period of uncertainty with associated stress, relationship difficulties, and financial and employment complications for both the person with young onset dementia and their family." So we've recently done some work to investigate young onset dementia diagnosis in New Zealand for the first time. And really we wanted to find out whether this is happening in New Zealand. Are these delays affecting New Zealand patients in the same way that they are overseas? So this work was funded by Alzheimer's New Zealand, and Shruti Sharma, who I've got a picture of there, did a lot of the work for this project as an undergraduate student. So what we did was, in a nutshell, we recruited people with young onset dementia and their care partners, and then we gathered information about their experience of getting a diagnosis using both questionnaires that were completed by the patient and their care partner, if they had one. And we also used medical records with consent to access those. At this point, I'd just really like to acknowledge all of the participants from around New Zealand who took part in this study for generously sharing their stories. Research always takes a long time, but this study has taken a particularly long time, partly because of COVID interruptions. So I'm really grateful for all of their patience with us putting this data together. So what did we find from this work? So on average, we found that it takes 3.6 years from a person first noticing symptoms to getting a diagnosis of young-onset dementia in New Zealand. This is very similar to the time it takes in Australia, and it's most likely quite a bit longer than it takes for older people with dementia to get a diagnosis. When we asked care partners what they thought about this, 40% of them told us that they thought it was too long. So for example, one participant summed up their experience by saying that the journey has been long and frustrating. So in terms of pathways to diagnosis, we found that there's a clear role for GPs in detection of suspected young onset dementia, because what we found is that almost all patients, so 92% of them, presented to their GP initially when they first noticed symptoms. Our New Zealand guidelines recommend referral to a specialist for all suspected cases of young onset dementia, and we do see this happening. So what we saw from this study is that 50% of GPs referred on to a specialist for diagnosis within 3 months of first seeing the person, and this is great. Unfortunately, a quarter of GPs didn't refer to a specialist for longer than a year. So we do think this is an area that can be improved in some cases. All patients were ultimately diagnosed by a specialist, and most of the time this was a neurologist. So 75% of the time people were being diagnosed with young onset dementia by a neurologist. So the next step in this project was to find out a bit more about the experiences that these patients and families are having. And to do that, we conducted these in-depth interviews so that we could really understand the experience a lot better. And this is work that was funded by Neurological Foundation's small project grant, and it's led by Dr. Ashley O'Mara Baker. So what Ashley's done is she has conducted 13 quite long interviews with care partners, patients and clinicians, and this is just in the Auckland region. And what I've done is I've summarised the main takeaway messages that Ashley has gleaned from these interviews here. So before diagnosis, there are often delays in presenting to the GP, and people found that they were referred to multiple doctors before they found one who could help them. They have also reported that there were discrepancies in the outcome of the diagnosis and also the experiences that they have, depending on whether they were using the public or private health system. And people also found it really hard to navigate issues around enduring power of attorney and advanced care planning. After diagnosis, so if we look over here, it was reported that services and resources that were appropriate for people with young onset dementia were really hard to find. And this included really limited options for day services and respite care and also long-term care options. And they also reported that funding systems are quite rigid and opaque, so really difficult to understand what you're actually eligible for in terms of funding. So what does all this mean? The work that we've done so far supports the following recommendations for clinical practice in New Zealand. So firstly, it's really important just to acknowledge that 7% of people living with dementia in New Zealand are actually under 65, so in this younger age group. And next, because almost all patients go to their GP first, there's a really important role for GPs in that initial suspicion of dementia stage. So when a patient or their loved one presents to their GP with concerns about their cognition or their thinking ability, the most important thing is for GPs to take a really detailed history and really listen to those concerns. So the changes that are happening are often really subtle and insidious. So patients can, for example, present quite well to the GP. That can look like there's nothing wrong. And it's really important that the GP trusts the loved one's judgment if they think that something has changed. Another really important point is that all suspected cases of young onset dementia should be referred to a specialist for diagnosis, as I mentioned. In most cases, this is probably best to be a neurologist, but it might be a psychiatrist, depending on the symptom profile, for example. And regional health pathways should really include guidance on these points. GPs also have a really important role to play in the management of these patients following diagnosis. So it's critical that patients and families are not left feeling like they've been given a diagnosis, which is distressing, and left to their own devices. In some cases, patients will have post-diagnostic follow-up with the specialist who has diagnosed them. But if not, they need to get this support in primary care from their GP. So at a minimum, we think that patients need information about their local dementia organisation, advice about living well with dementia, planning for the future, and also symptom management. So I mentioned before that age-appropriate services and supports are necessary, and I'm happy to report that these are becoming more available around New Zealand. So for example, Dementia Canterbury is doing some really amazing work in this area. Dr Campbell Heron is running a neurology clinic which specialises in young onset dementia in Christchurch. And Yodet, the charity that I work with, is running services in partnership with both Dementia Auckland and Alzheimer's New Zealand. Unfortunately, in-person services are not available everywhere in the country yet, but Yodet has teamed up with Alzheimer's New Zealand to run some online support groups, which are available to all New Zealanders. So for information about young onset specific services in your area, the best place to start is to contact your local dementia organisation, or you can contact us directly at Yodet. You can find our website easily. So, at this point, that's the end of part one. So I'll now stop sharing my screen and hand back over to Sarah.
Thanks for that, Brigid. It's really fascinating and often something quite hidden. Most of us would know people with dementia, but not so common to know someone with young onset. And I can see that would be, a real shock for the family, but also fantastic to see the work that you and others have been doing to get improved health services and resources in place. And I'm just thinking at the foundation, we need to make sure we've got that information on our website as well. So I'll make a mental note of that. But just a few questions before we move on to your frontotemporal dementia study. Do you know if epilepsy is a factor at all in young onset dementia?
It's not something that I've come across as commonly being a feature. No, it's certainly not my area of research. I'm not the best person to ask that question to, perhaps someone with a more clinical background, but it's not something that I've come across, no.
What is the most surprising or unexpected discovery from your research so far?
Oh, that's a good question. The most surprising, probably the fact that the ethnicity differences that we've found are actually even more pronounced in the younger group. We knew that across all ages there would be differences in the ethnicity, but really the differences that we found in the young onset group, just the magnitude of those changes, of those differences, surprised me.
Is there any understanding yet of why Māori and Pacifica have the higher incidence more so in the younger onset?
Yeah, that's a good question. My colleague Etu Mau, who has done a lot of this work with me, he has also done a lot of work looking at features that predispose people of all ethnicities to dementia, and he's done some really important work showing that Māori and Pacific populations are more likely to have some of those predisposing risk factors. And so I think it's probably the case that those risk factors are having even more of an impact in the younger group.
I think we've got time for one more question. So research has shown that there are pitfalls with early diagnosis, particularly starting with the GPs. So has this started to be addressed with GPs at all in New Zealand?
Yeah, that's a good question. So we've started to try and do some outreach, for example, by going along to GP conferences and presenting this sort of research. So that's definitely something that we are starting to do. And there's a lot of motivation amongst the GPs that I've had contact with, really to make sure that these patients are being treated as well as they can be. Obviously, GPs are, so busy and have to do so many different things and understand so many different types of conditions. And I think the important thing to recognise as well is that for GPs, many of them will go a long time in their practice without seeing someone with young onset dementia. So these are rare, it is a relatively rare condition. But yes, I think the awareness amongst GPs is definitely increasing in New Zealand, and that's something that we're all trying to keep improving in the field as well.
And before we move on, just a personal question for you. So you're running multiple studies, that you've got lots of different research staff and funding from multiple organisations. How do you manage all this?
Yeah, that's a good question. So one of the things that I really love about my job is working on multiple different projects. So it's I find it really interesting and exciting being able to have my fingers in lots of different pies. So I think that's a real benefit of the job. And it's a great thing about neuroscience in particular. I think that neuroscience as a discipline is really multidisciplinary. So from lab studies right through to brain imaging and cognitive testing on people. These are all things that that neuroscientists get to work with across different subjects. So that's the sort of positive side of it. In terms of the funding side of it, I'd obviously love to be spending less time on writing funding applications and more time on doing the actual research and helping people. But we have been really fortunate to have been funded by a number of different funders over the years. And this is particularly important for long-term studies like FTD-Gens, which I'll talk about in a minute.
Well, that's a nice segue into your FTD-Gen study. So why don't you, move into that one? Really excited to hear about what you found there.
All right. So I will just share my screen again. Right, so moving on to part 2. So now I'm going to talk to you about our study, FTD-Gens for short, and what we've been up to since this was established over 7 years ago now. So this work, as Sarah mentioned, is currently supported by a Neurological Foundation project grant and has previously been supported by a number of different funders as well. And all of this funding, and particularly the funding from Neurological Foundation, has been really critical for this project because it's a long-term project that requires ongoing support. And as you can see by the list of people here, I'm presenting this work on behalf of a really large team. So this is an inter-institutional multidisciplinary project, which includes a number of neuroscientists and clinicians. So this study is all based on the premise that the key to combating dementia is early detection. So clinical trials of Alzheimer's disease, for example, have been largely unsuccessful. And we think this is because we're trying to intervene too late in the disease process. So we know from studies of genetic Alzheimer's disease that the brain changes that underpin dementia are evident a long time before symptom onset. So up to 30 years before people develop symptoms, we can see some changes happening, and that's what's called this preclinical or pre-symptomatic phase. So the idea is that perhaps if we could identify people in this preclinical or pre-symptomatic stage, treatment might be more likely to work at that point. But to do this, we need pre-symptomatic biomarkers. So we need a way of identifying people who are in this pre-symptomatic stage. So these are critical for clinical trials of potential treatments. So we need pre-symptomatic biomarkers to identify participants to take part in these trials. We need them to predict the trajectory of their disease course, and we need them to track responses to treatment, so decide whether a potential treatment is working or not. So one way to identify these pre-symptomatic biomarkers is to study families that carry dementia-causing mutations, so genetic mutations which cause dementia. And the reason for this is that we can identify which family members will develop dementia in the future by doing a genetic test on them. So if the person carries the mutation, this can be identified at any point in their life, and they can be studied before they develop symptoms, many, many years before they develop symptoms. So this is what we're trying to do with FTD genes. We're working with a New Zealand family that carries a mutation which causes genetic frontotemporal dementia, and we're studying them over a long term, longitudinally, from young adulthood with the aim of detecting the very earliest pre-symptomatic biomarkers. And we hope that these pre-symptomatic biomarkers will be generalizable to types of FTD that are not genetic, because the changes in the brain are identical whether there's a genetic cause or not, and so are the clinical symptoms. But a question I always get asked is, what's the point of identifying dementia early if we can't yet treat it? So I think of research into treatments and research into biomarkers or early biomarkers as two sides of the same coin. So to be able to test potential new treatments, we need to identify people in the very early stages. And to do that, we need these early biomarkers. So these two fields of research really have to work together for us to identify successful treatments. So before I tell you more about the FTD gene study, I'm just going to briefly summarize frontotemporal dementia for those of you that aren't familiar with it. So frontotemporal dementia, or FTD, got its name because it affects two areas of the brain. The frontal lobe, which is shown here in blue, and the temporal lobe, which is shown here in green. So damage to the frontal lobe causes extreme changes in personality. So for example, people with FTD become disinhibited, they lose their inhibitions, which means that they can behave irrationally, impulsively, or inappropriately. Damage to the temporal lobe primarily causes language impairment. So people lose the ability to form sounds and say words, or to understand language, or to remember the meaning of words. So people with FTD will have damage to one or both of these brain regions. And that means that FTD is divided into two subtypes, so depending on the most prominent symptoms. So someone will either have the behavioural variant or the language variant of FTD. And you may be familiar with the language variant because that's the condition that Bruce Willis has recently been diagnosed with. So essentially, people living with frontotemporal dementia either lose either their personality or their ability to communicate, which is devastating, as you can imagine, for them and also for their families. So the main features of FTD that set it apart from Alzheimer's disease are that it's usually young-onset dementia, as I've mentioned, and memory impairment is not the first or the most prominent symptom. FTD is also much more likely to be inherited than Alzheimer's. So this is illustrated over here. So in about a third of cases, it's caused by an inherited genetic mutation. And these mutations occur in different genes, and the three most common genes that are affected are listed here. So in our study, the affected gene is called tau. And mutations in this gene cause the tau protein to clump together and basically damage brain cells. And this is what we then call a tauopathy. And what the tau actually looks like inside the brain can be seen here in this dark coloured stain here is staining up the tau inside a person's brain. You may have heard of tau because it's one of the proteins that is affected in Alzheimer's disease. So, how many New Zealanders are affected by FTD? It's not very common in older people with dementia, but it is one of the most common causes of young-onset dementia. And we think that about 2,000 people in New Zealand are affected by FTD. But we actually don't have very good data on that, which is something that we're trying to look into as a research team. So, going back to our study, this is a partial family tree of our cohort. And it's a large family. We're only showing some family members here to protect anonymity, but it is a large family. And the individuals in the family who have developed FTD are indicated in black. FTD Genes actually has its origins in a single donation to the Neurological Foundation Human Brain Bank. So there's another really nice point of intersection between the Neurological Foundation and my research career. Excuse me. So in 2006, one member of this family passed away and her brain was donated for research. Subsequent genetic testing revealed that the woman carried a dementia-causing mutation, and because of this, her family actually asked to be involved in research. So this project was really initiated by the family themselves, and it's been a collaborative process with the family all the way through. So in terms of the symptoms that this family exhibits, affected individuals have behavioural variant FTD, and symptom onset varies between a person's mid-40s and their mid-60s. The brain pathology, or the changes in the brain that we see, are caused by a mutation in the tau gene, as I mentioned, and this is what the mutation is called. This is the name of it here. So for the FTD gene study, we're interested in studying individuals in this family who carry this mutation but do not yet have any symptoms. So what have we done so far in this study? Our first step was to recruit participants into the study and to determine whether they carried the mutation. So were they pre-symptomatic mutation carriers or were they non-carrier controls, so people who don't carry the mutation? We started recruiting back in 2016, and it took about 2 years for all participants to have their first assessments. Our inclusion criteria included a minimum age of 25, because that's when we think we're most likely to start seeing changes. And the people had to not have any FTD symptoms because we're interested in pre-symptomatic changes. So we've completed genetic testing for all participants. This information is not shared with participants, but we do help them to access clinical genetic testing if they would like to know their genetic status. The research team is also blinded to their mutation status. So we ask participants not to tell us if they undergo clinical genetic testing. So as I've said, our aim is to identify pre-symptomatic biomarkers in this cohort. Essentially, we're measuring as many potential markers as we can, as you can see from this quite busy figure, and we're comparing these measures between the mutation carriers and the controls. So our participants come in annually. They get a blood sample taken, we test their sense of smell, and we also do a really comprehensive neuropsychology testing session. In addition to these annual measures, we have a number of sub-studies, including brain imaging, retinal changes, excuse me, so changes in the eye, social cognition and memory, and most recently, hearing and balance. So these are all measures that have the potential to be useful as very early biomarkers. So basically, we're testing as many different markers as possible. I'm sorry, I've got this awful cough. So it's really important that we do this testing over a long period of time so that we can see what's changing as people get closer to developing symptoms. So now to finish up, I'm going to show you a few highlights from the results we have so far. So the retinal study is led by our optometrist, Dr. Hannah Kirsten, who's shown here. She has used optical coherence tomography, which is an imaging technique that's used to obtain cross-sectional images of the retina. So in A here, you can see a photo of the retina, and in H, you can see a cross-section of the retina, with the retinal nerve fiber layers segmented into its various components. Hannah has used these images to measure the thickness of many different regions of the retina. OCT angiography is a technique that's used to visualize the blood vessels in the retina. And Hannah has measured many components of the retina using these measures, but she did not find any differences between the carriers and the controls at baseline. So we're now planning to repeat these assessments to see if we can identify changes over time. We have also analysed baseline data for cognitive changes and for changes in the brain using MRI. And this work was led by Dr. Ashley O'Mara-Baker with Professor Lynette Tippett and Professor Donna Rose-Addis. Ashley and our clinical neuropsychologist, Christina Elsa, have performed all of the testing, all of the neuropsychology testing. So the team has looked at many different measures of cognition, But in summary, we've found deficits across cognitive domains, including attention and processing speed, and also language. And this is even in patients who are up to 30 years prior to when we would expect them to have symptoms. We've also found reductions in the size of some brain areas, some of which are highlighted in yellow here in this brain image. Finally, in the blood plasma, which is a component of the blood that you can see here, this yellow part, our PhD student, Lydia Valtsian, has discovered that a group of tiny molecules called microRNAs and a group of proteins are either increased or decreased in people who carry the genetic mutation. And these changes are happening over time as people age. So we've seen this both at baseline and also longitudinally when we look over the course of time that we've been following these people. So this is really exciting for us because these could potentially lead to a simple blood test that could be done to detect the very early stage. So our results so far indicate that, as predicted, we are able to pick up very early changes in people who carry the gene mutation, even decades before they're expected to develop symptoms. This gives us confidence that our rationale is sound and that there is hope for preventative treatment. The next step is to validate these findings and see if we can identify a signature or a group of biomarkers that can be used to discriminate people who are in the very early stages of dementia. So, what's the point of this work? Why is it important and what impact will it have? As I mentioned, our next step is for us to collaborate with international studies to validate biomarkers of pre-symptomatic FTD. And as I mentioned in the beginning, these biomarkers are critical because they are needed to identify participants for clinical trials of new treatments. Ultimately, if early intervention is successful, these treatments could be used preventatively in patients with non-genetic and genetic frontotemporal dementia. And finally, it's possible that these biomarkers that we're investigating currently may be relevant to other dementias, including Alzheimer's disease. So that's why we're doing this work. We hope that with the ongoing support of funders like the Neurological Foundation, we can continue this work and contribute to the global effort to prevent or treat dementia. If you'd like to hear a little bit more about the FTD Gen study, including from the family themselves, RNZ did a really lovely podcast about the study a couple of years back, which you should be able to find online. So with that, thanks to all of my collaborators who I've listed here, and special thanks to all of these people and groups who've helped with participant recruitment. Most importantly, thank you to the participants themselves, the FTD Gens family, and all of the funders, of course. And thanks to you all for listening.
Fantastic. Thank you, Brigid. If you've got any voice left, we'll do a few questions.
I'm so sorry. I knew that was going to happen. It's been fine all day. It's always the way, isn't it?
Yeah, when you have to constantly talk, that cough can come back when you think you've got over it.
Exactly. I think I'm fine. I think I've got it under control.
Well, thank you very much for keeping going with that. So does young onset dementia fall under rare disorders in New Zealand?
It does, yes. So I guess it's an interesting question because young onset dementia isn't a different clinical entity. So as I said at the start, the separation between young onset dementia and late onset dementia is biologically arbitrary. But if we do define young onset dementia as a single entity, in terms of the numbers who have it, it does fall under that category of a rare disorder. Yeah.
So is there any research looking into the part that diet and lifestyle play in the development of dementia? And I think there's two questions here. So one would be, what are the general sort of diet and lifestyle factors, and are these risk factors more prevalent in Maori and Pacifica? Is that why we see the higher rates there?
Yeah, that's a great question. So for dementia at any age, those risk factors apply. So these are things like basically a healthy lifestyle. So getting enough exercise, eating a healthy diet, those sorts of things. So doing those sorts of things will reduce your risk of getting dementia at any age. And yes, in some cases, those lifestyle indicators are potentially contributing to the higher rates that we see in Māori Pacific. In terms of the effect of diet and lifestyle, there's also some really interesting research that's come out of some work that some of our international collaborators have done. And they've looked specifically at families with genetic FTD, so just like the family that we're researching in New Zealand. And they've found that even if your dementia, in this case your frontotemporal dementia, is directly caused by a genetic mutation, your lifestyle, particularly in this case, the amount of exercise that you do, actually still impacts on that disease process. So what they showed was that people in these families who had a healthier lifestyle in terms of the exercise that they were doing actually developed the symptoms later in life. So they were able to stay protected from those symptoms starting for longer. So even when people have a very direct genetic cause, those lifestyle changes can have an effect. So yeah, certainly the advice is for all of us to be really trying to have that healthy diet and exercise.
So the saying, what's good for your heart is good for your brain?
Absolutely. Yeah, absolutely.
So we have a question about a young onset dementia service in Tauranga in the Western Bay of Plenty, which is fantastic. How do they let people know that their service is available?
So I think the easiest way for most people to find out of these services is if they can go through the local dementia organisation. So if any services are available in a particular region, they should make themselves known to the local dementia organisation, and that's usually where people get in contact with first. We also host this information on the YODAT website. So if anybody wants to get in touch with YODAT through our website, we're happy to put that information up on there, which is another way that people might be able to find out about it.
Great, thanks for that. Interesting question about whether you've heard of EHT brain supplements.
I have not. That's a new one. That's a new one to me.
Yeah, I haven't heard of that one either.
Yeah, I would say in general, unless there's something that's come out very recently, there isn't any good evidence that any individual supplements are helpful for preventing dementia, unless someone is deficient in a particular molecule. The advice is that really the best way to have that healthy diet is from improving your diet rather than taking supplements.
Okay, that's a great tip. Thank you. Do you know about the research going on at Macquarie, where they say they've cured FTD in mice? Would that be a genetic therapy?
Probably. I'm not familiar with exactly what they're talking about. It's quite possible that it is a genetic form if it's in a mouse model. There are a number of really promising genetic approaches to treatment for FTD. At the moment, most of those are dealing with different genes. So I mentioned at the beginning that there are 3 genes that can be mutated in frontotemporal dementia. In some cases, it's the tau gene, which is relevant for our family. In some cases, it's another gene called progranulin or GRN. And in other cases, it's another gene called C9orf72, which is also mutated in ALS or motor neuron disease. Most of the genetic therapies that are currently being looked at are dealing with those other 2 genes, so the progranulin gene or C9orf72. So improving or dealing with those genetic issues in the tau gene are a little bit more complicated, unfortunately. But there are clinical trials happening already focused on genetic treatments for people with those other 2 types of mutations.
I know you mentioned your work is making it more accessible for New Zealanders to be able to get into these clinical trials. Are there any New Zealanders in clinical trials for FTD at the moment?
I'm sure there would be 1 or 2. I'm not aware of any, but I'm sure there would be some New Zealanders who have accessed clinical trials overseas. yeah, that's a really important point. So part of why we think carrying on with the study is really important is that what it means is that the people in this individual family will be really well placed to be involved in international clinical trials when they do start happening. And we'd also really like to be able to expand the work that we do to include any other families with genetic FTD in New Zealand, if there are any other families out there for the same reason.
So if people want to get involved in trials of this or any other neurological conditions, if they want to be involved in research, does the university have a place for them to contact?
The university does, yeah. So the university has information on trials or research studies that are happening specifically at the university. If people would like to have information about trials that are happening overseas in terms of FTD, they're welcome to contact me directly. I have international collaborators who are occasionally looking for participants from around the world. And one really important point is that with quite rare conditions like frontotemporal dementia and particularly genetic frontotemporal dementia, there are so few patients around the world that we really need to get participants from many different countries to have enough people to run these trials. So even having a handful of additional people from New Zealand can really make a big difference.
Well, that's really exciting that you're a conduit for that in New Zealand. We have a question about the link between untreated deafness and dementia. And I noticed you've included in your study now hearing imbalance, and this is becoming more widely known about the risk factor of deafness and dementia. Do you have any comment on the link between untreated deafness and dementia?
Yes, so I don't know about tinnitus specifically, but certainly untreated hearing loss in general has been very well shown to be a risk factor. So if it is treated, then your risk goes back to normal, back to what it would have been before you had hearing loss. But yeah, certainly getting hearing loss treated is a really important thing to do to decrease your risk, and that will apply to the young onset as well as the late onset, I would imagine.
I'm just gonna, oh, right. Just there's a lot of stuff going on in the chat, which is fantastic. But another question, is there a link at all to Parkinson's disease?
Yes, so Parkinson's disease is an interesting one. So there is a specific subtype of dementia called Parkinson's disease dementia. And what that refers to is when a person has Parkinson's disease, in some cases, they can also develop dementia as part of their symptom profile. So not all people with Parkinson's disease develop dementia, but some people with Parkinson's will develop dementia. And if they do, then that's described as Parkinson's disease dementia. There are also other similar or sort of related types of dementia called Lewy body disease. And in this case, these people don't have Parkinson's disease, but the affected protein, which is called alpha-synuclein, is the same. So these people have an issue or damage to that alpha-synuclein protein, and that causes Lewy body dementia rather than Parkinson's disease. So there's quite a lot of overlap between Parkinson's disease or Lewy body disease and dementia.
So we've got people asking about preventative treatments. Is it still just the what's good for your heart is good for your brain lifestyle factors, or do you know of anything else that could potentially be preventative?
Yeah, so in general, it's really those lifestyle factors. So there's some really good resources actually. I think Alzheimer's New Zealand might have quite a good summary of those what we call modifiable risk factors for dementia. So if you Google dementia modifiable risk factors or have a look on the Alzheimer's New Zealand website, they've got a nice summary of it. But yeah, in a nutshell, it's basically a whole lot of healthy lifestyle things. One of the less obvious or more surprising things that can reduce your risk of developing dementia at any age is actually maintaining social connections. So people who still have a really active social life seem to be protected to some extent from developing dementia, which is really interesting.
Yeah, I've heard a lot about sleep being really important as well.
Yeah, that's one of the ones that's definitely getting a lot of attention, and it makes sense, doesn't it? Just in general, I think a lot of those healthy lifestyle things are also linked into getting the right amount of sleep. So yeah, I would definitely say there's no harm in trying to make sure that your sleep is good.
So if someone's gone to their GP because they've got concerns about their memory, and they've tested in the normal range, is there anywhere else that they can go, maybe privately, or what would you recommend?
Yeah, that's a really good question. The difficult thing, so I'm assuming that this person means that they've had one of the cognitive screening tests. So that might have been something like the mini ACE, which is the recommended screening test in New Zealand at the moment. And this is used as quite a simple screening tool that GPs can use to determine if someone's cognition is in the normal range or not. One of the issues with these types of tools is that they're not perfect. So in some cases, people can be in the early stages of one of these types of dementia, and they can still pass these tests and look like they get a normal score. So for example, sometimes people with frontotemporal dementia actually do pass those tests in the beginning, and that's because those tests don't necessarily capture the specific symptom profile that someone with frontotemporal dementia might have. So that is something that the GP will be aware of, but it does make those screening tools a little bit complicated sometimes to interpret. So my advice, if that has happened, would be to first of all to talk to the GP again and just say, look, I realize that that the result was normal, but I really still have concerns, particularly if you have a care partner as well who's noticed changes. It's always really good having someone else to come along and explain what they've noticed. And if you're not making any progress with your GP, I would try and ask for a second opinion. So either going to a different GP or potentially asking for a referral to a specialist.
Thanks very much for that. Let's just have a look. Yeah, we still have some more questions coming through. There are some people with early FTD diagnosed with mental disorders prior to the recognition that it's dementia. I remember you said some were referred to psychologists or psychiatrists.
Yes, yeah. So in some cases, depending on the symptom profile, it can be really difficult to tell the difference between a psychiatric condition. So for example, something like generalized depression can sometimes affect someone's cognitive ability. And those sorts of conditions can sometimes be what we call primary psychiatric conditions, can be really difficult to distinguish from some of these young onset dementias. So what we saw in the diagnosis study that we did was that when people present to their GP with symptoms that could look like either a psychiatric condition or a young onset dementia, that did make that diagnostic process more complicated. So it can be a really difficult thing for doctors to figure out. And the best approach in that case is to get input from a number of different specialists. So having a psychiatrist and potentially a neurologist both having input into the symptoms would be the best approach in those circumstances.
Is there somewhere online where people can access a list of common FTD symptoms?
I'm sure there will be. We do have a brief outline of FTD on the YODAT website again, which is yodat.org.nz. Otherwise, I can get back to you on that, Sarah, actually with another website to have a look at. I'm not sure off the top of my head.
Yeah, we'll have a look at putting some information on our website as well, and just passing on some extra questions to you if we haven't managed to get through them all. But I've just noticed that it's now 8 o'clock, so it's time just to say a huge thank you to you for your time tonight, especially since you're still getting over a cold, and just presenting the fantastic work that you've been doing, just improving services for people in New Zealand with dementia, and also just really keeping that research going to work out how to detect it earlier, in the hope that, yeah, when there is treatments available, that you'll have these biomarkers to be able to get these treatments to people earlier and prevent dementia. It's a really exciting time in the field, I think.
Yeah, absolutely. And yeah, apologies again for all the coughing and spluttering. At least it's over Zoom, so I'm not spreading my germs around. And yeah, just a huge thanks to Neurological Foundation and all of the Neurological Foundation donors. We really couldn't do any of this work without all of you.
Thanks very much to everyone for joining us, and I'll be closing off the webinar now, and it will be going on our website over the coming week or so. So thanks again, and have a great night.